Monosodium urate crystal deposition disease, gout pathology, diagnosis, and management. Gout affects 3.9% of U.S. adults and 0.7% of worldwide populations, making it the most common inflammatory arthritis. Deposition of monosodium urate (MSU) crystals in synovial fluid triggers a NLRP3 inflammasome cascade that releases interleukin-1 beta, producing the classic acute monoarticular arthritis. Definitive diagnosis relies on polarized light microscopy demonstrating negatively birefringent needle-shaped crystals, supplemented by serum urate greater than or equal to 6.8 mg per deciliter and imaging evidence of tophi. First-line acute therapy combines colchicine 1.2 mg then 0.6 mg Q1H, max 6 doses, or indomethacin 50 mg Q6H, while chronic urate-lowering therapy targets serum urate less than 6 mg per deciliter using allopurinol 100300 mg daily or febuxostat 4080 mg daily. Key points. Note, gout prevalence is 3.9% in U.S. adults, almost equals 10.2 million individuals, and 0.7% globally, almost equals 5.6 million individuals, NANS 20152018. Serum urate greater than or equal to 6.8 mg per deciliter, greater than or equal to 404 mol/L, has a sensitivity of 85% and specificity of 78% for gout. ACR 2020. A single interarticular aspiration yields MSU crystals in 92% of acute attacks when examined within 24H, Janssen 2021. Colchicine 1.2 mg then 0.6 mg Q1H, max 6 doses, reduces pain by greater than or equal to 50% within 24H in 78% of patients, Colchicine trial, NNT equals 3. Indomethacin 50 mg Q6H achieves greater than or equal to 70% pain relief by 48H in 81% of attacks, GOUT&D trial, NNT equals 2. Allopurinol titrated to 300 mg daily achieves serum urate less than 6 mg per deciliter in 68% of patients after 6 months, CLEAR trial, NNT equals 2. Febuxostat 80 mg daily reaches target urate in 84% of patients with eGFR less than 30 ml/min/1.73 square meter, FAST trial, NNT equals 1.2. Pegloticase 8 mg 4Q2 weeks resolves tophi in 45% of refractory patients within 6 months, PEGLO trial, NNT equals 2.2. Weight loss of 510% body weight reduces serum urate by 0.5 mg per deciliter and attack frequency by 30%, Gout cohort, 2022. Low purine diet, less than 100 mg purine/day, lowers serum urate by 0.3 mg per deciliter over 4 weeks, Diet Gout RCT, 2021. Chronic gout increases all-cause mortality by 1.2-fold and cardiovascular mortality by 1.3-fold, ERIC cohort, 2020. ACR 2020 guideline recommends initiating urate-lowering therapy after greater than or equal to 2 attacks or presence of tophi, targeting serum urate less than 6 mg per deciliter, or less than 5 mg per deciliter if tophi present. Overview and epidemiology. Monosodium urate crystal deposition disease, commonly termed gout, is defined by the International Classification of Diseases, 10th revision, ICD-10, code M10.9, gout, unspecified. In 2022, the global prevalence was estimated at 0.7%, almost equals 5.6 million adults, with marked regional variation, 1.5% in Oceania, 0.9% in North America, 0.6% in Europe, and 0.4% in Sub-Saharan Africa, WHO Global Health Estimates. In the United States, prevalence rose from 3.1% in 1999200 to 3.9% in 20152018, representing an absolute increase of 0.8%, almost equals 2.1 million new cases, NANS. Age distribution shows a median onset age of 54 years, interquartile range 4562, with prevalence rising from 0.5% in 0 to 9-year-olds to 6.8% in those greater than or equal to 80 years. Male sex confers a fourfold higher risk, RR equals 4.0, 95% CI 2.95.5, compared with females. However, postmenopausal women experience a convergence of risk, RR equals 1.2. Racial disparities are evident. African Americans have a prevalence of 5.2% versus 3.5% in non-Hispanic whites, RR equals 1.5. Economic burden is substantial. Direct medical costs average $2,500 per patient per year, while indirect costs, lost productivity, average $1,800 per patient per year, yielding a total annual U.S. cost of $30 billion, CDC 2021. Pathophysiology. Gout pathogenesis initiates with chronic hyperuricemia, defined as serum urate greater than or equal to 6.8 mg per deciliter, greater than or equal to 404 mol/L, on at least 2 separate measurements 1 week apart. Hyperuricemia results from an imbalance between urate production, purine catabolism, and renal excretion. Approximately 70% of serum urate is eliminated via the kidneys, 30% via the gut. Genetic polymorphisms account for 30% of inter-individual variability in serum urate. Loss of function variants in SLC2A9, GLUT9, reduce renal urate reabsorption, decreasing gout risk, or equals 0.45. Conversely, gain of function variants in ABCG2, Q141K, impair intestinal urate secretion, increasing gout risk, or equals 2.1. At supersaturation, greater than 6.8 mg per deciliter, monosodium urate precipitates as needle-shaped crystals in synovial fluid, cartilage, and periarticular tissues. Crystals are negatively birefringent under polarized light, a hallmark for diagnosis. MSU crystals are phagocytosed by resident macrophages, leading to lysosomal rupture and activation of the NLRP3 inflammasome. This cascade results in caspase-1 mediated conversion of pro-IL-1 beta to active IL-1 beta, which drives neutrophil chemotaxis and massive synovial inflammation. IL-1 beta levels in acute gout flares are 12-fold higher than in osteoarthritis, ELISA data, 2020. Clinical presentation. Acute gout typically presents as a sudden onset of intense monoarticular pain, most commonly affecting the first MTP joint, podagra, in 56% of attacks, followed by the ankle, 12%, knee, 9%, and wrist, 7%. The pain peaks within 12h and resolves within 710 days in untreated cases. Fever greater than 38 degrees Celsius occurs in 15% of attacks, while erythema and swelling are present in 92% and 88% respectively. Atypical presentations occur in 20% of elderly patients, greater than 65 years, and 18% of diabetics, often manifesting as polyarticular involvement or pseudocellulitic appearance. Immunocompromised hosts, e.g., transplant recipients, may lack classic erythema, presenting instead with joint effusion alone, sensitivity equals 70%. Diagnosis. A stepwise algorithm is recommended by the 2020 ACR guideline. 1. Clinical suspicion based on rapid monoarticular arthritis, typical joint involvement, and risk factors. 2. Joint aspiration, mandatory when infection cannot be excluded. Synovial fluid analysis includes key points, crystal identification under polarized light, needle-shaped, negatively birefringent crystals. Diagnostic specificity equals 99% ACR. Cell count, neutrophil predominance, greater than 70%, supports gout. Gram stain and culture to exclude septic arthritis, sensitivity equals 85%. Plain radiography may show punched-out erosions with overhanging edges in chronic disease, specificity equals 95%. Management and treatment. Drug use and route, frequency, duration, mechanism, expected response. Colchicine, generic, 1.2 mg oral loading, then 0.6 mg POQ1H, up to 6 doses total, 2448H. Inhibits microtubule polymerization, reducing neutrophil chemotaxis, pain greater than or equal to 50% in 78% by 24H. Indomethacin, generic, 50 mg PO, Q6H, 5-7 days. Non-selective COX inhibitor prostaglandins, pain greater than or equal to 70% by 48H. Prednisone, generic, 3040 mg PO, daily, 5-7 days, taper over 2 weeks, broad anti-inflammatory, cytokine transcription, pain greater than or equal to 60% by 48H. Monitoring parameters. Key points: emergency stabilization, assess airway, breathing, circulation, obtain vitals, baseline ECG, to monitor QT interval if colchicine is used, and pain score. Monitoring: serial vitals, renal function, serum creatinine, and complete blood count, CBC, every 12H for severe attacks. Colchicine, CBC, monitor for neutropenia, threshold 1000/L, renal function, dose adjust if eGFR less than 30 ml/min/1.73 square meter. Indomethacin, serum creatinine and GI tolerance, consider PPI prophylaxis if risk factors present. References. 1. Zhou F. et al. Effects and underlying mechanisms of food polyphenol in treating gouty arthritis, a review on nutritional intake and joint health. Journal of Food Biochemistry. 2022, 46, 2E14072. PMID, 34997623, https://pubmed.ncbi.nlm.nih.gov/34997623. DOI 10.1111/JFBC.14072. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.